Welcome, everyone. Obviously, everyone here and also everyone watching online as well, to the book launch of Dealing with Dizziness, Holistic Solutions for Unexplained Chronic Dizziness, Vertigo and Balance Problems by Dr. Sean Rai, the founder of Vitality Chiropractic, where we are today. My name is Svein. I'll be your host for this afternoon. Firstly, a bit about Vitality. Vitality Chiropractic is the only chiropractic clinic in Singapore that deals specifically with upper cervical specific care. In addition to clinical treatment, they also conduct research, contributing to various scientific and medical journals in the field of chiropractic. The founder of Vitality, Dr. Sean Rai, has helped more than 5,000 patients overcome various complex medical conditions like chronic dizziness and migraines. Beyond his clinical work, he is also a community leader who serves as the vice president of the Alliance of Chiropractic here in Singapore. He is also the chairman for outreach and charity events for the organization. To learn a bit more about the author of the book and the journey of the book itself, please join me in welcoming Dr. Sean Rai, who is sitting here. Yep. So, there we go. There we go. Can I call you Sean?
Sean is fine, yeah.
Good. Okay. The doctor gets a bit mouthy after a while. So, you're obviously a chiropractor, but now also an author. I'm curious, what sort of set you on the path and what compelled you to actually start writing a book?
I just want to say thank you for everyone for being here today. I know especially around New Year, it's a busy time of year for everyone with family. So it's really started for me, I guess when I first started, I wasn't thinking about dizziness. I was thinking about these complex cases. I knew lots of colleagues who were seeing very intense headaches, migraines, facial pain for their patients. And that's initially where I thought my career was going to be going down. And then it's only because I had a patient come in who was experiencing dizziness. He experienced what's called Meniere's disease, a very specific condition. And with this condition, he was having a lot of dizziness. He was having problems with his ears, hearing on one side. He was having ringing. And I talked with some mentors I had at the time, and they said, yeah, this is something that we see quite a lot. Actually, someone who's referenced in the book, he runs an institute where they've been doing research for the past 30 years just about Meniere's disease. So I talked to him about this, and he said, yeah, this is something you should definitely see. So again, it's something we studied dizziness at university. I knew it would be a part of my practice. I didn't know how much it would become a big part of it. But with this patient, we had really good results very, very quickly. And so it was clear, okay, maybe this is something which is a bit more underserved. So my knowledge really at that time was just what you would see at university. It was a couple of select cases I'd seen in the UK and then when I came here. But in terms of the length of the scale and how many people are experiencing dizziness or other balance-related issues, I was honestly a bit unaware. So only when I started doing research, I found studies from the UK talking about up to 10 to potentially even 20% of the population will experience chronic dizziness. So not just one bout of feeling a bit off balance, but chronically feeling dizzy for more than 3 months at a time. So after seeing this, I was looking at the different options that people had, and even an article that came out from CGH here in Singapore showed that around 70% of the people that were going in for tests when they were going to see their ENT, 70% of those people that came out with no diagnosis.
Wow.
With no diagnosis and no real forward treatment. They were basically given a spectrum of, these are some medications, some exercises, and some stretches you can do, but there was no definitive thing for them to say, this is what you should be doing. And the more I would start to see patients like this, the more we would see these positive results. That's where I realized, okay, I need to do more about this. And honestly, I started writing this book 4 years ago. But then, life gets in the way, things have been happening, and it's only really in the past year or so that I put more into it to get it finished and get it ready to be there for the public.
Whoa, okay.
So it's been a while.
4 years, all right. So when we spoke earlier, you mentioned an interesting thing. And that was during the research and writing of the book, you faced a terminology issue, essentially, about dizziness. There's obviously quite a few conditions linked to it, but there was no term or no word for it that would sort of cover all of it. So you had to create one, essentially?
To an extent, yeah. So the term I have for this because it is an umbrella of lots of different things which can affect it and it can present in people, would be a chronic vestibular spectrum disorder. So because I was looking at the different things, and even as I've been in practice, the diagnoses have actually changed. So one of the diagnoses changed to what we now would call PPPD, so it's more about perceptual positional vertigo. But I realized between that, so PPPD, cervicogenic dizziness, POTS, even Meniere's disease to an extent, they all have such a big crossover in terms of the symptoms and the ways that we test for them. Because for a few of those, there is no definitive cause. So when you think about a condition or a disease, you think about, say as an example, one of the other conditions of the ear, it's called labyrinthitis. It's very specific, it's viral or bacterial, it will produce horrible vomiting and dizziness and vertigo for a patient. They know which medication to give, and that's the fix. We know exactly what causes it. In the same way that you could talk about any kind of condition, you could talk about, say, a certain type of stomach issue, and we know exactly what the cause is. For a lot of those, there is no definitive cause. There's no what we call a gold standard. A gold standard is a way that you can do a test that says, yes, this is definitely this. A lot of them are really what we would call syndromes. A syndrome is something where there's no definitive cause, but I think when we put the words together, it kind of makes sense. So we're going to say that this is that. And that's what a lot of these were, because really for, again, at least 4 or 5 conditions, if you put them together, you could use the same kind of treatments, the same kind of tests, and you get exactly the same results.
Wow.
So between cervicogenic particularly and, say, PPPD, for both of them, you could say if you turn your head, you're going to feel dizzy. But then how do you tell really which one is which? Okay. And also by having a label, sometimes it's a bit confusing for patients, because they'll go to see a GP, an ENT, and a neurologist. They'll get 3 diagnoses, and then they'll be very, very confused. They won't know what to do. And so the next step for them is really, it's not about the label, it's how do I deal with this? Yeah. And that's really what the spectrum is supposed to be looking at, more of how do you deal with it, not just trying to give someone a label that then they're told to live with, which isn't very helpful for them. Okay.
All right, so it's quite interesting that during the whole writing process, you actually had to coin a completely new term to sort of enter into this. Huh. Okay, so as part of this then, I was wondering if you could share a bit more about what we get to read about in the book itself. Mm-hmm. In terms of maybe you have some excerpts or something like that from it.
Yeah, sure. So if you want to actually have a look at the screen, we've got a few things prepared over here. So in these different parts, when I was writing the book, I didn't want it to go straight into just like, I'm a chiropractor, here's what chiropractic is. That's not going to be very helpful for most people. And realistically, there are a lot of people who, they should never see us. So we need to have a useful guide for them so they can actually get some things they can manage themselves and do first. So the first part is actually going to be going through the words dizziness and explaining a bit more about the terms. Because for the majority of people, if you said to them dizziness, giddiness, or vertigo, they would kind of confuse them together quite commonly. And one thing, if you ever talk to somebody who has one of these problems, they'll get fairly offended if you get it wrong. And especially for a family member, if someone is reading this and they if they have a family member who maybe experiences one of these and they say, oh, you have just a bit of giddiness and having vertigo, which makes it feel like the whole world is spinning, they get hurt. And it's then hard for them to talk to people about this more. And even I've unfortunately seen this with even medical professionals and other practitioners where they get it a bit wrong as well. So it's giving a bit more of an idea, mainly for sufferers and for their family members, to understand what the differences between them are, so that they can classify themselves a bit better. Because for certain things, it will make it easier then to know what kind of path they should take. So I think that would be in the next slide. So I think it'll be on, say, 1 or 3. On the top, sorry, say 1 or 3. Chapter 1. Okay, so we go to the next one, sorry. So that would have been chapter 1, that'd be going through the words. The next part is going to be going through some of the misconceptions. So some of the things that people may think about when they think of dizziness or vertigo. People say vertigo, a lot of people think of like heights, especially because of a very famous film a very long time ago. They think of heights. However, that's not really what true vertigo is caused by. So we'll go through some of those misconceptions, some of the things I get asked on a regular basis to explain to people what the simple terms are. We can go to the next part. And then for the next part, going a bit more into the anatomy, not going too far in. Of course, we're not trying to make this into an anatomy textbook, but to help people understand that there are different parts and systems in the body which contribute to your balance and how these can be affecting. So most people, when they think about, say, dizziness, they're going to think about the inner ear. And absolutely, it's called your vestibular system. It is definitely a big part of balance. However, there's also your visual system and your proprioceptive system. And the proprioceptive system is about 70 to 80% of your balance. But when I say proprioceptive, most people don't know what that means. And essentially that's going to be explained more in the book, but it's really about how you can perceive things, so whether it's your muscles, your joints, your tendons, how they can then pick up where you are in space. If you put your feet on the floor, you have an idea you're on the floor. Then your ear will help you know if you're upside down. Your eyes, when they're open, are going to let you know if you are upside down or not. So they all work together as systems, but in a more simple way, I've tried to explain the anatomy so people can understand more about what's happening with them. Because for some people, they may notice that if their eyes are open, that's when they start to feel more dizzy. Well, then they know, well, they should know from that, then hopefully, that it's more a visual system problem rather than the vestibular system. So it's not the ear as much in that case, but it is potentially something happening with their eyes. And then it's a bit more about how they all correlate together. Cool. We can go to the next part. And the next part is going through some of the more common conditions. So some of which are the things like I mentioned under that spectrum, but some of the things we will not see at all. So say BPPV, labyrinthitis. If anyone called our team and told us that they had any symptoms that may correlate with those things, we ask them to go straight to their medical doctor. We're not seeing them because that's not the right fit for us. So really the book is not just again about coming to see me, it's about a real guide for people about what they should or should not be doing based on their symptoms. Because some people, like with any symptom, they may have something and they'll think, oh, it's going to wear off, it's just going to go away. But hopefully, say as an example from labyrinthitis, if someone has read this and they know it's coming on and they feel these intense symptoms, they know I should go straight to the hospital. I should not sit at home because otherwise it could lead to potentially permanent damage for their hearing. Okay. So it's trying to give people a practical guide of how they can stay safe before taking some of the other steps, as well as going through what the common tests and treatments are. So when they do go and see a doctor, they have an idea of, oh, these are the things I should be expecting. But if the doctor then, or whatever practitioner they see, doesn't do some of those tests, they know, okay, maybe I should be seeing someone else. I should get another opinion because these are what the normal tests are for this. Because it's hard to know. People look online and there's so many different pieces of advice that they can go through. So we can go to the next part. Thank you. Okay, and then should be going through some of the other options that people have. So this is not going to be, again, even getting into our care, but talking about exercise, going through yoga, going through the supplements, which actually have research behind them. Lots of different approaches that people can take alternative to medical care if they've already been to see their medical professional and it hasn't been as effective. So there's other things that they can try either by going to see a different type of alternative practitioner or things they can do in their own time. So one more, thank you. And the last one will be going through more about our care, explaining about what we're doing, again, explaining that really we want someone to have seen, say, an ENT or someone first, make sure that everything is clear and safe. But then if things are not responding for that 70% of people, how can we then maybe help them into a better sense of balance?
Okay. Yeah, so it's quite interesting to me because this makes it sound like, it's a book that's both for your colleagues and peers in the chiropractic industry, but it's also for, the average Joe. For example, for me, when you mentioned the part about vertigo, I'm guilty of that. If someone tells me anything about vertigo, I'm just thinking, okay, it's a fear of heights and, get over it kind of thing. But as you say, there's so much more behind that as well. So I think a lot of readers probably appreciate sort of, the way it will explain a lot of these concepts in it as well. So, I mean, there's obviously a lot of patients that you've helped with your methodology, but I'm actually quite interested to know how a typical chiropractic treatment or scan or introduction would be. Is it possible to show this in real life here? I mean, I can volunteer. But...
Thank you. So I can explain a bit about the initial process. So usually before somebody comes in, to make sure that we are the right fit to help them, we actually will have a call. Either myself or my colleague or the team will have a call with the patient to discuss with them about some of their symptoms, see if we're even the right fit for them. If there's certain, like I said, there's certain conditions, especially say if maybe they've been to see the GP and they've indicated that is what's going on with them, we'll refer them straight to someone we think is the best fit for them. So first is kind of triaging to understand more about what's happening and make sure that, of course, there's no medical emergencies. Because sometimes someone may say a few symptoms and they may not think anything of it. But myself and my colleague may be thinking, that's a red flag, go to A&E right now. So trying to first discertain if we should even see them at all. And then when somebody does come in, the first part is always going to be a consultation. That's where we're going to go through more about their medical history. We're doing a full physical assessment and we're doing nerve scans. The nerve scans I can show you today. And then at that point, if we believe it is helpful, that's where we would send for a specialized type of x-rays. Okay. As you can actually see a kind of little example just on there.
This one.
I believe they're my x-rays. Palpations on there. And then the next time after that, we have the test results, and that's where we explain where we go at that stage, if we can help, and if we can, we would start on that day.
Okay.
So you want to come to it, I can show you what I mean by the nerve scan.
Just before we do that, there was one more thing that I actually had on my list of questions as well, is obviously within the book, I will assume that you draw on a lot of your experiences that you've had with patients that obviously have had issues and then have been solved through this. Are there any examples or anything you can share with us? Any of these stories in the book that we should pay attention to or be especially aware about?
Yeah, so in the book, I've tried to split it into different parts. In the beginning of each part, we have a story about one of our patients that has come in, and these are the ones where I've talked to them, they've agreed to be part of this book. But the one I've put in the beginning, I put him there because he's actually a friend of mine.
Okay.
So his story was a bit different. We were talking about this, and like he's at the moment, it's an interesting thing because he's doing so much better now, and he's about to be a father, so he's in a much better place. But about a year ago, he was not doing very well. He was having a lot of problems with balance. It was making it difficult for his work. It's something he'd had in varying lower intensities when he was younger, but then it came back a lot worse as he got older. And then it became this thing where usually he would expect it kind of would just pass on itself. And this is what a lot of people do with a lot of different symptoms. But then it just kept getting worse and it was not going away. And he tried all the normal things and it wasn't really helping. And so for him, that's one of the big stories we have right in the beginning, showing how it was about around 2 to 3 months, but it was something which initially for him started over 10 years ago. And now he's got into a much better place where the checkups, I see him once every maybe 3 to 6 months, something in those ranges. But now his balance has gone back to normal. And he's one who had been to try everything first. And even though he is a friend of mine, I've known him for a long time, honestly, he didn't come to see me first. He went to an ENT, a neurologist. He went to every specialist he could find. He even got second and third opinions and went for everything from an MRI and everything else. So he tried everything. And again, the doctors were very good. They were very professional, but they just weren't finding the right kind of thing. And then when we did our scans, which I'll show you in a second, instantly I said, hey, I can see something going on.
Really?
It was very, very clear what was happening with his case. It's a process. It wasn't instant, but his results, within a couple of months. I was expecting it might take up to 4. It was more like 2 to 3. We started to see very significant changes. Then he was stable pretty much from that point.
Okay. Well, then I'm very keen if you can.
Yeah, if you want to come on
to
through
the show.
Yeah. So I'll show you what's happening with the scan. So if you can all come on through. You can kind of peek from the door. Okay, you can have a seat facing this way.
This way.
So these will be the nerve scans. For the scans, I use this device. It's what we call computer thermography. All it does is run up the back of the neck like this, and it's more of a test of what's happening with the nervous system. So all we're going to do from here, so I'm going to bring this a little bit further back if you don't mind.
Do I need to sit somehow, like slouch? Or?
No, that's perfect. Hopefully your chiropractor never tells you to slouch. You have your head slightly forward. Then from here, you'll hear a beep. And it's just going to run up the back of your neck to there. Okay, we'll do that one more time. Okay, so for these scans, when someone comes in for their first appointment, we'll be doing this 6 times. So that'll be 2, but the thing is, if you do too many in a row, it can start to affect the efficacy and the efficiency of the efficacy and the quality of the test that we're doing. So it's something we would always spread them out over the 45 minutes to an hour when we first see somebody, and that's going to give us more of an insight into the nervous system. So to be honest, you do have a bit of a finding on your scans. We want to see essentially more straight, more balanced lines. We don't want to see what's called a pattern. A pattern is when there's a problem. It's kind of like, say, if someone is late for things, if they're late once, they're late once. If they're always late, it's a pattern, it's a problem. Similar for blood pressure, for other medical tests.
So you have to come back later on.
Okay, and then after any time, so say after we've done all our tests, we've got x-rays, we know what's going on, that's when we would have adjustments. So based on the x-ray, that would let us know if we should be adjusting and how we should be adjusting. The scans then correlate to make sure we are seeing real changes, not just is the person feeling better, that's very important, but really also what's happening objectively for their changes. So you want to come across, I'll give an example. We won't be adjusting because of course we haven't got any x-rays. Okay. But say from here, what I want you to do is to have your knees here and here, in the middle of the pad. You can have your glasses off, they can go up top here. And you can have your right ear here facing towards me. Okay, so I'll guide everything. From here, the palms are facing up, shoulders are nice and loose, letting the belly button drop down to the floor. Okay, a little bit more if you can, very good. Again, just as an example, We're finding the spot we find based on the x-rays. And then from here, I'll be taking a contact point. My hand would come over, and then there'll be a very small push coming down that way. And then you can come up, sorry. You can walk.
Oh, yeah, still.
And after any time we would have an adjustment, we would always have time in the recovery room. And this is about speeding up the process and the results for our patients. If you want to come through, I'll show you what's happening in the other room.
Okay.
So it's just behind this sign over here. We have our recovery room.
It's very hidden.
Oh, it's okay. Thank you. So through here is our recovery room. So after any time someone would have an adjustment, we'd always have time in here. The adjustment helps get the bone in the right place, pressure off those nerves. But all the muscles are like tight elastic bands. They're used to the old position. So if you were to get straight up and go outside, it would start to slowly pull things back. That slows down recovery.
Okay.
And this is just all about speeding things up. So time in here would be 15 to 30 minutes after any time we adjust. And there'll always be another scan to make sure we do have that improvement. So it's not about improvements over weeks or months. It would be on the day. So that's why we check the scans afterwards. And that's why we have different kind of arrangements. Say some of the benches as well, they all rise up because we do have a lot of patients with dizziness. So if they're having dizziness and they're laying flat, for some people it's unbearable. So that's why some will need to be seated, some will have in more of an incline. If they can, then they would be laying flat. And then we'd scan afterwards to make sure and confirm we do have that change.
Okay.
Any questions from any?
Do you usually see big changes before and after the treatments?
In terms of the scans? Yeah, absolutely. If the scans are not changing, that's where myself and my colleague, we need to look and say, okay, maybe we need to change our approach. Maybe something isn't quite right here, and make sure that we are seeing those changes, because without those changes, it won't be symptomatic changes. You need to have that scan change as well, which is very important. Good question. Nick?
So usually the patients that come here, they can feel the effect in like one session, is it?
No, not usually, to be honest. There are some people where they will feel, but no, it's more the scan will change, the more of that objective change. In terms of the feeling change, there are absolutely some people who feel, to be honest, amazing after their first time. But for most people, especially when it's chronic, it does take time. So it's not always going to be an instant change. It's something that can take, say a couple of weeks at a time. But usually within around 2 weeks, that's where we start to see these change for our patients.
I see.
Okay, any other questions?
Not anything. Well, most people usually fall asleep in here, or
It's funny you say that. So when they first started doing this kind of technique around 100 years ago, the goal was that people would fall asleep. So they used to have hospital gurneys, and they would have people for 2 hours with the mentality at the time of, if kids sleep more, they'll grow better, they'll heal better. Same for adults, so same if we're doing a technique. Okay. Now we have more research, we understand we don't need to have that long. It's called creep of tissues. It's about 13 to 15 minutes. But yeah, that would have been the goal. But some people do fall asleep, and every so often someone does snore. Does happen.
Okay. That's good.
Okay. So you can come on through.
Yeah.
Have a seat.
Thanks.
Oh.
Okay.
Right. Well, that's quite interesting to sort of see the workings of it as it was. And as you mentioned, it's the full cracking and creaking and stuff is when you've had the scans and you know what you're looking for and what you're fixing.
Yes, absolutely.
Okay. At this point, I'd like to ask if there's anyone on the floor that has any questions in terms of either about the book itself, about the work of Dr. Shan, or about chiropractic in general. If there are anyone, then now's the time. And if we are fairly timid today, that's also fine. I actually... Oh, yeah.
Because I was going through what they said as well. So are all your case studies based on your patients in Singapore?
Yes.
So, okay. So it's a Singapore-centric kind of case study, like based on your book itself.
Yes, absolutely. So I've been in practice for about 11 and a half years. 10 of those years have been in Singapore.
Okay.
So most of my patients have been based here in Singapore. But anyone who's mentioned in the book, they're all our patients who are from Singapore. And even the case studies, we also have some studies we had published last year, separate to this book. All are based in Singapore, and same with the ones that are coming out this year. All based in Singapore.
Yeah, because I think there were 3 case studies that were like in appendix that were sent to us, but when I opened it, there was no like Singapore reference. So I just wanted to
Yes, they're all based there. Yeah.
Very good. Okay, then I actually have a few questions that I thought of before as well. You alluded to it earlier that a lot of people they'll go to the GP, they'll go to ENT, they'll go to a lot of specialists, but based on your experience with your patients that you've helped, do you get the sense that sometimes there's a bit of a stigma or a fear almost to bring this up with your friends or even your GP? I mean, if you're again just the average person in the streets,